So next up we have a 43-year-old woman is thrown from a car following a car crash. She presents to the emergency with a fracture of the pelvis. Her blood pressure is 80/60, pulse is 110, and the respiratory rate is 26. Now, there is bright red blood on the rectal examination, and bony fragments can be palpated through the rectal wall. The patient has received, the patient remains hypotensive despite 3 liters of resuscitation with renal lactate and 2 units of type specific blood. So after these resuscitative measures, what is the most important step in the management? So would it be expiratory laparotomy and colostomy? Would it be external fixation, PASG, fresh frozen plasma, and wiring of the symphysis pubis? So again, this is a pelvic trauma scenario and the patient is hemodynamically unstable. So you have to make sure that anything that is going to improve the status of the patient should be the next step. So that would be external fixation of the pelvic fracture. So let me explain this with the flowchart to have a better understanding about the pelvic trauma management. So regarding the pelvic fracture management, you have to see whether the patient is hemodynamically unstable, which is the organ that you are suspecting as part of the pelvic injury, and what is going to be the management of the bony fragments. So if the patient is hemodynamically unstable, the very first step, especially in the trauma room, is to apply a pelvic binder. This is followed by external fixation. And after application of an external fixator, if still the patient is hemodynamically unstable, then you can either go with embolization or free peritoneal packing to the space of trapezius, that is a lower midline laparotomy, where sponges are rapidly packed in the pelvic area to have a compression effect over the pelvis. Now, if there is a suspected urinary bladder injury or urethral injury, what is going to be the algorithm? So for the urethral injury, you have to see whether the anterior urethra is damaged or the posterior urethra is damaged. Now, in the scenario of a pelvic fracture, most likely is the posterior urethra being damaged. Now, if there is an anterior urethral injury, then the scenario will be giving you hint like any instrumentation or saddle injury. Now, what will be the management in whatever the scenario? So, you have to pass Foley's, which could be urethral, but it is usually advised to avoid urethral catheterization. What we do is the suprapubic catheterization. Now, this is followed by the surgical repair or complete resection depending upon the degree of injury. Now, urinary bladder injury is divided into extraperitoneal injury and intraperitoneal injury. For extraperitoneal injury, there is non-operative management, that is through Foley catheterization for 1 to 2 weeks. If there is an intraperitoneal injury, it always requires a surgical repair with both urethral and suprapubic Foley's. Now, you need to know all these algorithms because they are frequently tested in the trauma MCQs. I have explained these in the trauma series as well. If you want a much clear information on these, you can also check those videos as well. So next up we have, with regard to the neck injuries, which of the following statement is true? So these type of questions are a bit difficult because you need to have a lot of information and you must be very much aware of all the necessary things that you need to know about the neck injury or any specific area which is tested, so that you can correctly identify the correct statement. So in this, the options are: internal jugular vein may be ligated unilaterally without unfavorable sequelae, unilateral ligation of the common carotid artery resulting into 90% of neurological deficiencies. Esophageal injuries should be drained externally only when extensive revitalization. Tracheostomy is indicated in dealing with most laryngeal or tracheal injuries, or injuries to the trachea must be drained externally. So out of these options, A is correct, and let me explain this as well. So in the patient who has no neurological deficit preoperatively, every effort should be made to repair a carotid artery. So what we do is we perform a 4-vessel angiography, especially in stable patients in zone 1 and zone 3 injuries. I will explain these zones again in a coming MCQs. Careful judgment should be exercised in selecting patients with zone 2 injuries who are to have an angiography, that is, a suspected injury to bilateral common carotid or vertebral arteries, or in selecting those for observation. Carotid artery ligation must be employed in patients who are unstable without a high incidence of neurological deficit. So, the internal jugular vein can be ligated on one side with minimum long-term consequence because there is a rich venous channel network present from the collaterals. However, bilateral ligation can result into raised intracranial pressure. However, unilateral ligation of the common carotid artery does not result into 90% deficit but actually cause 10% or less. All esophageal injuries in the neck are quite serious because they are going to result into mediastinitis and sepsis and require drainage. So external drainage is always indicated for all the esophageal injuries in the neck area. Tracheostomy is not always indicated in the laryngeal or tracheal injuries because many patients can be managed with the ETT as well. Tracheostomy is actually reserved for the cases who have a paired airway for those who have an airway compromised, severe damage or failed intubation. Like they are not used for all the cases. Tracheal injuries do not require external drainage. Management depends upon the extent and location of the injury. However, small tears can be managed conservatively or primarily repaired without the need of drainage. So next up we have the injury most often missed by the selective non-operative management of the abdominal stab wound. So by selective non-operative management, it is implied that the patient was conservatively managed and what injury is likely to be missed in conservative management. Would it be colon, spleen, ureter, diaphragm or small bowel? So in a case of stab wound, especially in the abdomen, if the patient is held conservatively, then the likely organ which is going to be missed is the diaphragm. Now, selective management, that is the conservative management, especially in the lower chest or upper abdomen, is going to rely on number 1, that is physical examination, and number 2, that is the DPR. Now, what happens is in scenarios of small diaphragmatic injuries, the DPL is not going to be positive, that the RBCs will not be up to the mark to call it positive. As a result, they can be missed. So, missed diaphragmatic injuries can result into late presentation with the diaphragmatic hernias, which have high mortality and morbidity. So, you should need to understand that what is the algorithm which is used for conservative management and what are the indications in a stab wound which will lead directly towards the surgical management. So again, I have added this flowchart to help you with the algorithms. So if you have a strong grip on the algorithms, you're not only going to get good marks in your MCQs, but they are also going to help you in your clinical scenario in real life. So the patient presents with the abdominal stab wound. The first step is to follow full ATLS protocol and assess the stability. So if the hemodynamically unstable patient is present, then we will directly go with the laparotomy. However, if the patient is stable, then we will look for the sign of peritonitis. Actually, this is the flowchart which I had drawn previously with my hand. I have added this in a different form. So, whichever is easy, you can add them in your notes and do follow these flowchart algorithms that are going to be very beneficial. So, if again the patient was stable, but there are signs of peritonism or evisceration of any viscera, then again laparotomy is going to be your answer. However, if the patient is stable and there are no signs of peritonitis, then you will be going with the local wound exploration. So in that, you have to assess whether the patient's fascia has been breached or not. If it has not been breached, then you will go with the discharge. However, if the fascia is breached on local wound examination and the patient is stable, we have established that we will go with the CT scan of the abdomen. Now, it is going to help us to quantify the pathology. If there is a hollow viscous injury and there is an active bleed, then we will go with the laparotomy. However, if there is a solid organ injury and the patient is stable, then patient will be observed. Now, in a normal CT, observation will be the management. Now, when you're observing a patient, there are certain important things that you have to check for the hemoglobin. You have to check for the renal function test, and you have to see for the abdominal gait, because these and you have to also check for the blood pressure. Now, if any of these parameter is taking the patient in showing that the patient is going into shock, then you will directly shift your management from conservative to surgery. So if you follow these algorithms, it is going to be very easy for you to solve these MCQs as well. So next up we have a 40-year-old female who presented to the emergency following a car crash. Now, in the emergency, her blood pressure is 80/60, which shows that she is hemodynamically unstable, pulse is 128, and respiratory rate is 32 beats per minute. Now, she is complaining of right-sided lower chest wall pain and severe right upper quadrant tenderness. So, if this is going to be the chest area, in addition to this, there is going to be involvement of the right upper quadrant as well. So, what two areas of organs which could be present? So, either there could be a lung pathology, or there could be a diaphragmatic injury, or the liver could be involved. So, these are the three things which you have to keep in mind following the next thing which could be asked. Now, what is going now? They are saying that her breath sounds are questionably diminished. So, they have localized your diagnosis to the right-sided lower lung. So, either there could be hemothorax or pneumothorax. So, what they have asked now? Now, the immediate priority is to confirm which of the following. Would it be peritoneal lavage, chest X-ray, CT scan, thoracocentesis, and endotracheal tube? Now, these 2 points can be easily excluded because they will be done in a stable patient, and out of these, the better option is CT scan. Now, as we have already established that our patient is hemodynamically unstable, and we are suspecting that there could be either a pathology which is causing a decreased sound, which could be hemothorax or pneumothorax. So our option would be thoracocentesis, because endotracheal tube intubation is done if the airway is compromised and there is no information regarding this. So this can also be excluded. So in a patient who is having respiratory distress in addition to shock, there is adequate problem present with the breathing, and it takes priority over the circulation. Because as I've already explained that the ATLS protocol says that you have to go with this sequence A, B, C, D, and E. So if there is that you have gone through the breathing and you were assessing the circulation, but you found, or your member of team found, that the patient is desaturating or there is decreased chest expansion or any abnormality, then you will stop the circulation. Or you can do two things, that you will identify one of your team member to save the circulation, and the team leader or the senior member will try to assess or manage the breathing part. So this is how you manage a trauma patient. So I will explain this with a diagram, and in this they have said that the insertion of a 18-gauge needle is used to rule out pneumothorax, and it is going to be a diagnostic value. So even if you do not know this algorithm, what I have explained, if you follow that sequence, you can easily rule out other options, as there is no need for peritoneal lavage, as there is no indication for liver injury or any abdominal visceral injury. So let me explain that what is pleural space. Now, if this is the parenchyma of the lung, adherent this would be the visceral pleura, and then there will be the pleural space, that is this area, and outside of that would be the parietal pleura. Now, if there is any pathology that could be observed over here, that the fluid has started to collect in this space present between these two pleuras. Now, what that pathology is going to do, it is going to compress the volume or the area of the lung. Now, this can be assessed on the X-ray, and before that, as our patient was unstable, we will be putting a needle in this area to drain this fluid or drain this air. So, in both cases, followed by this thoracocentesis, chest tube is going to be the management. So next up we have a 30-year-old woman brought to the emergency after stepping on a rusty nail and sustaining a puncture wound on the foot. The patient has been on a therapeutic dose of steroid for past 5 years for ulcerative colitis. She has her last tetanus toxoid booster given around 8 years ago. So what should be the management, or what should the patient be given? So should it be tetanus toxoid booster? Should it be given human immunoglobulin, antibiotics with anaerobic coverage, tetanus along with human immunoglobulin, or tetanus plus human immunoglobulin plus antibiotics for the aerobic as well as anaerobic coverage? So in this scenario, the best option would be to give all these things to this patient, which includes the tetanus toxoid, human immunoglobulin, as well as antibiotic to cover for the bacteria present in the wound. Now, tetanus toxoid along with these two is going to play an important role in the management. Patients who are taking steroid or are immunocompromised should receive human immunoglobulin even if they are previously immunized. So that is a new point that should be added in your notes. Now, tetanus booster and antibiotic therapy are also necessary, because the most important thing is the patient is taking steroid and they reduce the immunity, as well as she is also having ulcerative colitis, which has some autoimmune pathology. So, in both the scenarios, the patient is rendered immunocompromised. So, in those scenarios, you have to give some extra to the patient so that they do not develop any complication. So, whenever you're encountered with a tetanus vaccination scenario, I would advise you to follow the algorithm which I have described below. So, very first step is to classify the wound. That what is the wound type? So, whether it is a clean or minor wound, that is, there is no contamination, it is superficial, and there is minimal tissue damage, or the wound is dirty, contaminated, has more than 6 hours into your presentation, whether there is some frostbite, burns, or there is a gloss contamination or crushing injury. Now, once you have classified the wound type, then you will see that what is the immunization status of the patient. So, has they received more than 3 doses of tetanus toxoid and they're fully immunized, or whether they have only received less than 3 doses or their status is unknown. In those cases, they will be considered unimmunized. So, once you have established the class of the wound and their immunization status, the next step would be to determine that which type of tetanus prophylaxis this patient is requiring. So, if the patient is having a clean or minor wound and they have received more than 3 doses, that is the required algorithm for tetanus, there is no need. But if they have received a booster dose and it was more than 10 years, then you have to give them some management. If the patient has a wound which is other than the clean or minor wound and they have received more than 3 doses, you will be giving them booster dose if they have more than 10 years history of taking any previous toxoid dosage. Now, if the patient has taken less than 3 doses or their immunization status is not known, then if the wound is clean, then you will go with the tetanus toxoid only. But for the dirty wound or any contaminated wound and the patient having either unknown status or less than 3 doses, which renders them high risk, then in that scenario, not only the tetanus toxoid but also the immunoglobulin along with the antibiotics is going to be your treatment of choice. So you have to be adding antibiotic in this as well. So again, a flow chart for the tetanus wound management. So first of all, you have to classify the. So that is the very first step. So once you have classified whether it is a clean or contaminated wound, then you check for the immunization history. So if the patient is having more than 3 doses and the wound is clean and they're having less than 10 years of history, then you have to do literally nothing. So if the wound is clean and they have all the required status, but it has taken more than 10 years, then only a booster dose is the treatment. But if the patient is having a dirty wound and you're having less than 5 years, then you do not need to give them any vaccination. But if there is a dirty wound and the time is around more than 5 years and the patient is high risk in this scenario, then you will be adding a single booster dose. But if the scenario is saying that the patient is having unknown status or they have had less than 3 doses, that is the incomplete vaccination status for the tetanus, for clean wound, you will be giving tetanus toxoid only. But for the dirty wound or the high risk patient, you will be adding immunoglobulin in addition to that.